For everyone with an interest in MASH, or more broadly, metabolic-associated steatotic liver disease, Surf's Up. Doesn't that roll off the tongue? Season 4, Episode 48 of Surfing the NASH Tsunami, our interviews with some of our best friends about what they're looking forward to at the Liver Meeting 2023, starts now.
Today on Surfing the NASH Tsunami.
One of the ones that I thought was interesting was there's a session on MASLD from tweens to 20s, steering towards improved outcomes. And the reason why I'm looking forward to this is because I have not seen a lot on pediatric NAFLD. It's out there, but the literature and the information for pediatrics is less.
What do you anticipate will come out of that session?
Well, I think a lot of it will be the long-term effects and the cardiovascular effects because, we just don't have a lot of data, but the data that's out there is pointing to a really significant impact. One of the things that really fascinates a lot of people, I think, is artificial intelligence. And when I saw that session coming up on artificial intelligence for the diagnosis and treatment of liver fibrosis, it just made me have a lot of confidence in the AASLD that they're really cutting edge and really paying attention to where the field is going. And so this looks like a really nice session.
As we prepare for the Liver Meeting 2023, Surfing the NASH Tsunami is interviewing some of our guest opinion leaders on what they find most exciting about the upcoming agenda. Today, Roger Green speaks with endocrinology key opinion leader Dr. Scott Isaac about sessions and themes at TLM 2023 he anticipates most eagerly.
Hi, this is Roger Green, host of the podcast, soon to be officially rebranded Surfing the NASH Tsunami. This week, our plan was to record an episode on the liver risk score, but that fell apart at the last minute due to some conflicts that only emerged on Monday. We were unable to record this week. We hope to have that interview for you at a later point in time. So next on the release schedule, and pushed up a few days, was the preview run-up to the Liver Meeting 2023 from AASLD, which takes place in Boston starting on November 9. The original plan was to record several interviews that we would release on the week that starts on October 30th, but we are stepping that up a little bit. We will do one or two of them the end of this week and 2, 3 or more over the course of next week. Each will be an individual interview with one of our favorite guests discussing what that person anticipates most eagerly about TLM 2023. Fourth and final discussion in this series is an interview with our friend hepatoendocrinologist Scott Isaac. Scott will talk about some of the sections in the meeting that he finds exciting and some of the trends that he's seeing as hepatologists, endocrinologists, and other specialists come together to look at the broad range of metabolic diseases. I hope you enjoy. Here we are with our fourth interview of TLM interview roll-up week with our good friend Scott Isaac. Scott has been part of this podcast a few times and part of our Rising Tide series as well. In the world where people are now creating multiple specialties, Scott is what some have described as a endocrinologist by training, who does an awful lot of work on metabolic disease and liver space. Scott, how are you this afternoon?
I'm doing fine. Glad to be here. Thank you.
Always happy to have you with us. So you mentioned you're getting to Boston on Thursday, and you said you had one poster that you're involved with the meeting. Let's bet it. Before we get started, just what's the poster?
Well, it's a poster about GLP-1 agonists and non-alcoholic fatty liver disease.
Okay. Is it embarked, or can you tell us a little more about it?
It's a poster with Intercept Pharmaceuticals looking at their medication and how GLP-1 use affected the outcomes in their studies. So it's kind of like a sub-analysis.
Interesting. And without going into too much detail, what did we learn?
GLP-1 medicines don't seem to make a huge difference when they're on that other medication.
All right. That makes sense. I mean, we may come back to this in this conversation, and if not in a subsequent episode, because some of the team and I have an evolving theory about how to think about the development of the markets around the disease, which we might come back to on this conversation or not. But let's go to the easy place, okay? Easy and hard. Tremendous amount of exciting stuff going on in the meeting. Are there one or two papers, presentation sections that you found particularly exciting or compelling you want to tell our audience about?
Well, the short answer is yes. I'm really looking forward to this meeting this year because there seems to be a lot on the agenda about metabolic dysfunction associated steatotic liver disease. So really looking forward to this. One of the ones that I thought was interesting was there's a session on MASLD from tweens to 20s. Steering towards improved outcomes. And the reason why I'm looking forward to this is because have not seen a lot on pediatric NAFLD. It's out there, but the literature and the information for pediatrics is less. And so it's exciting to see that and more about MASLD in pediatrics and young adults, because this is an area that's just exploding. The epidemiology, the rates are increasing. And what's really interesting is that teenagers and young adults with steatotic liver disease have a very significant increased risk of cardiovascular disease later in life, 20 and 30 years later. And so it really has long-lasting implications.
That's fascinating. I agree with you. I'm really excited about that session. I always love listening to Mazen, who's part of one of those, I think. But Dr. Stavros Antakos from Cincinnati, please forgive me if I butchered your name, Doctor, because we've not met, published a paper, I guess, a couple of months ago called The Rising Tide of NAFLD and Used the Warning Bell and a Call to Action, which was, I think, a rather fantastic read. I'll be really interested to hear what she has to say about all these topics. So what do you anticipate will come out of that session?
Well, I think a lot of it will be the long-term effects and the cardiovascular effects, because, we just don't have a lot of data, but the data that's out there is pointing to a really significant impact. And, it may be that a pediatric MASLD is a little bit different than what we see in adults, and the histology seems to be a little bit different. We don't see a lot of hepatocyte ballooning in pediatric steatotic liver disease, and it may be that it's a more aggressive form when we see it in the pediatric population. And so it really seems to have this long-lasting implication and also affects the entire body, because these patients are at increased risk for type 2 diabetes, for polycystic ovary syndrome, and for other metabolic-related illness.
Yeah, so I think that's a fascinating point, which is at the meta level. Let's go from children to adults for a second, and then I'll come back to kids. 35% of all adults in the world have fat on their liver, but that doesn't always translate into NASH, right? Or MASH, point one. Point two is that from F0 through F3, the leading cause of death is not liver-related. It tends to be cardiovascular or other things, right? So when I think personally, and that's one of the things I'll be interested to get out of this session about kids with MASLD, I don't necessarily think about the implications for liver disease, but I go where you went, which is diabetes, cardiovascular.
I totally agree. I guess as an endocrinologist, that's always where we're looking. But I think the liver is really an innocent bystander, in that the underlying pathophysiology is with obesity, insulin resistance, inflammation. And so as an endocrinologist, we look at the liver as end organ disease, same as we might see retinopathy or neuropathy or nephropathy. But of course, there is unique pathophysiology within the liver too, especially the part that goes from the steatosis to fibrosis and the mechanisms that are occurring. So there's this combination of the insulin resistance and also these factors unique to the liver.
And that is the interesting question to me. In fact, if you think about liver disease in its own right, MASLD, okay, or MET-ALD, either one, an awful lot of people have fat on their livers. Not all those people are ever going to develop fibrosis. So right now, we're at a point in time, because of the drugs that are available and because of the concomitancies with the other metabolic diseases, where I think there's exceptional focus on how do you reduce the percentage of people who have fat on their liver. In essence, the metabolic frontline attack. Over time, what I expect will emerge in the disease, and one of the things I'll be looking at in this meeting, is some of the other moments of truth. One of the other interviews next week that we're going to be publishing along with this one is one with Naeem Al-Khoury, where he talked almost exclusively about cirrhosis and some of the cirrhosis studies, and the fact that now you're way downstream, right? Because now you're past fibrosis, but there are different issues around cirrhosis that predict outcome, right? I mean, so if we can manage portal pressure, if we can find drugs that are capable of reversing fibrosis in those populations, then in fact we can avoid the really onerous moments of truth or the worst forks in the road around cirrhosis. I expect there are going to be similar questions around fibrosis. So when you said that it's a different disease in pediatric and teen than it is in adult, one of the questions I've not seen a lot of work on yet, and I don't know that there is any, but you can tell me because you would know far better than I would, is whether we've taken a look at whether the fork in the road by which adolescents get to fibrosis looks and feels different than that process for adults. Is there literature that you're familiar with? No, I'm not. That's why I ask. Totally open question.
I'm not either, other than it does seem like there's some differences. I think there's some similarities as well, but this is definitely an area that we need more information on, and it just kind of brings me back to why I'm so excited about attending this session at the meeting, just so I can get a good understanding of where we are now.
We completely agree. Similarly, another set of issues that I've heard about from other folks looks at combination therapy that incorporate the incretins, and specifically particularly GLP-1, with other different kinds of drugs now to see if there's some kind of accumulative effect or interactive effect, to the better or the worse. There's some papers on that in this meeting that I'm aware of, a couple of them under embargo right now. Have you been looking at anything like that? Is that in the area of interest for you?
Of course, combination therapy is an interest because it's the way that we treat a lot of diseases. It's the way that we treat diabetes, hypertension, congestive heart failure. And so it only makes sense that with the drugs that are available and then the drugs that we anticipate will be available in the future, that combination therapy is going to be the most effective, especially because these medications work via different mechanisms of action. So we would expect a complementary effect or an additive effect, and we certainly see that in these other areas. And so really excited also to see the literature and what's coming out in combination therapy.
Tell me about a couple of other specific papers or sections in this meeting that you find yourself interested in.
You know, one of the things that really fascinates a lot of people, I think, is artificial intelligence. And when I saw the session coming up on artificial intelligence for the diagnosis and treatment of liver fibrosis, it just made me have a lot of confidence in the AASLD that they're really cutting edge and really paying attention to where the field is going. And so this looks like a really nice session. I know that I saw Mary Ranella and Rohit Lumba are on the panel, and it's looking at the integration of artificial intelligence into the diagnosis and treatment and looking just at a basic understanding of this. And there's so many areas for artificial intelligence, from decision making to assessing non-invasive testing to pathology. I think that's going to be a very cool session to attend.
There are a boatload of AI papers. One of the things I'm personally excited about is if AI allows us to transition from CRN fibrosis scoring or even Ishak fibrosis scoring to a more continuous variable so that we can look at fibrosis in greater detail, I think that would be hugely helpful, and I think the session that you pointed out is one that I expect will go there. I know that HistoIndex and PharmaNest and PathAI all have a bunch of stuff at this meeting, much of which addresses those kinds of issues. Is there something specific that you're going to be looking to take out of that kind of talk?
What you just mentioned is a really cool thing to be able to sort of really nail down diagnosis and risk stratification. I think that the coolest thing is that there's sort of unlimited possibilities for AI, so I'm really looking forward to hearing what's out there now.
I think that's going to be 3 or 4 frontiers at once, really. Number one, there's a question about disease progression. There's a question about better scoring. There's the question you raised about adolescence, right? Which is this might be different diseases in different subpopulations. And some of the pictures and the clarity of the pictures that you can get from AI might enable us to sort that out a lot better than we have right now. Besides the coolness of it, do you have any pet hypotheses of your own that you're just hoping will bear out in what we hear or what we learn over time?
I guess my thought is that it may take some time before AI is really user-friendly for this, where it's something that we could plug into our EMR or get a score or something like that. So I'm not sure, but I think that this is just going to be sort of just tipping our toe in the water and just getting an idea of where things will be headed in the future.
I know there's a PPAR late breaker in PBC from GenFit, from elafibranor, and there'll be several PPAR papers. I don't know what Lanny is producing because they're in the middle of phase 3 right now. There'll probably be some reanalyses of those. But I think of the PPARs as being drugs that were originally developed for diabetes and really, originally in endocrinology, but are now starting to be applied here. As an endocrinologist who treats liver in the metabolic complex, are there things that you can glean from the use of PPARs in PBC, or is that too many football fields over to be of value to you?
I might be able to partially answer that. As an endocrinologist, PBC is not an area I'm really up to date with, but what I can say about PPARs is that clinically, I use them a lot. They are not that well used among the endocrinology community, and I think there's a growing understanding that they are beneficial in a lot of ways, not just for steatotic liver disease, but for improving the lipid profile, for reduction in cardiovascular disease and other cardiometabolic factors. And so the limitation of PPARs are side effects, and especially people are concerned about weight gain, about effects on bone health and on fluid retention. And so with the newer PPARs, I think that's where, the excitement is to get the benefits with fewer side effects. And I know that we still have had a lot of challenges with side effects, even with the newer agents, but hopefully we're going to find one that has that balance that's going to be an improvement to what already exists.
Yeah, that is the hope. One of the things to look at, even in PBC, would would be to say, so what does Ella do for side effects compared to other available agents, right? Because metabolism is different, but side effects to some degree are side effects. So if that side effect profile is meaningfully better than what we would anticipate, then although you can't prove it until you do the studies, you would think it might say good things about the next generation of PPARs, or at least that PPAR, in the context of being able to achieve the goal you're talking about.
Yes, and the side effects are relative too, and the fact that they're not always as bad as people fear, and especially the weight gain. For most patients, if they're already taking metformin or GLP, the weight gain is minimal or none for the vast majority of people, and so we shouldn't be afraid to use them. And if patients do have side effects, it can always be discontinued. But what I see in the endocrinology community is an underuse of PPAR medications.
Okay, so now other things you've seen in this meeting that you're particularly intrigued about.
Well, one of the things that a lot of people have been excited about for now a couple of years is the nomenclature change, changing the name of NAFLD to MASLD and fatty to steatotic. And even though we've come out now with the consensus statement, the reality is now that it needs to be implemented. And so I'm looking forward to this session on steatotic liver disease nomenclature implementation symposium, because after 180 people got together for a long time and followed a rigorous process of changing the name, now we have to make it stick. So we've got a whole bunch of papers that are coming out that still have the old nomenclature because they were submitted, a long time ago, and now there's going to be that transition. So it'll be really interesting to see how this is going to be done in an effective way to implement this new nomenclature.
It's interesting. Have you been working to implement in your own practice to date?
I do. What I do right now is I write NAFLD/MASLD because I don't want to just stick with the old terminology, and I'm afraid the new terminology, people won't know what it is. And so I've been using the slash right now to kind of put it both there. And that's just my own doing. So I'm curious to see how other people are doing it.
I think that'll be fascinating. I agree with you. So I'm at this point, candidly, we're looking at different logo and visual options to change Surfing the NASH Tsunami into Surfing the MASH Tsunami. We're through the rest of it, which is why if you listen to the intro to this episode, I frequently allude to the idea that the name is still NASH, but not for long, for that reason. But I think there are a whole variety of practical issues. And I agree. Naeem made an interesting point in his conversation with us also, which is that the reason this had to happen was because people had jumped the gun on the name change. And when they jumped the gun on the name change, they also created the definition change. And the definition change had some really potentially threatening effects on drug development and diagnostic development. So the question was how to solve the problem so that you incorporated the vision about what might you want to do with the name of the disease, and at the same time not affect drug and diagnostic development, which seems to have occurred. Now, as you point out, the question is how do you educate patients, because that gets messier and sloppier.
Yes. But you have a really good point about name change versus definition change, and it would be a disaster to change the definition with all the clinical trials that are going on, all the criteria for the trials, plus all the papers that have been previously published. And so with the new nomenclature, having the categories and having the sort of classic NAFLD as MASLD, but then also having new definitions for new subcategories, I think is really helpful. Really interested to hear more about MET-ALD. I think it's something that we see a lot, but we don't always recognize it, partially because patients don't always tell us how much they're actually drinking, partially because we don't ask. But I'd be interested to sort of learn as time goes on how that might be addressed a little bit differently other than just telling patients not to drink. And so I think that's interesting. And then also looking at the other parts of the nomenclature as well.
See, it's interesting you should say that. I think MET-ALD was the first thing everybody got excited about in the nomenclature change because that was such a large proportion of patients and nobody really knew how to define it, who they are, and then what to do about them. So I think that's an excellent point. It strikes me that will have a lot of practical play out to endocrinologists also, not just hepatology, because in fact, you're probably seeing these people because a lot of them are obese or diabetic before you ever get to a point of thinking about their liver.
Well, I'm thinking about their liver from day one, but I think that may be the case for a lot of people.
But that's why you're a hepatoendocrinologist in a world of endocrinologists. I mean, that is the point, right? So one of the other interesting things I'm going to look for is papers on the incretin agents. More on GLP-1 certainly, but the dual agents and the treble agents. When people talk about GLP-1s, one of the issues they talk about is tolerability. I think some of the studies we've seen with the dual and the treble agents suggest that might become even more of an issue.
I mean, the tolerability, it can be an issue, but I think with the agents that are out there, with the right counseling and setting the right expectations and doing a titration, I think most of the tolerability is manageable, especially if you counsel the patients that, to stop eating as soon as they feel full and not to eat past that point. A lot of them end up doing really well, and then they get past the initial side effects. What I think has been really interesting to see is, and this is more anecdotal, but I think I've heard some about this, is that with dual agent, with tirzepatide, there seems to be fewer side effects. And I have seen some papers where they look at GIP as an antiemetic agent. And so perhaps there's a little bit less nausea with tirzepatide compared to semaglutide, say. It's just, and in my clinical experience, that's also the case. But having said that, I think even with semaglutide, people eventually tolerate it for the most part. There are a few that don't. But retatrutide, which is the triple G, it seems like the nausea is more significant. The side effects are more significant on the triple. And the discussions have been that this drug is so powerful that it's probably going to be more reserved for the people with severe obesity that really need a potent agent because of the increased side effects.
So I'll be interested to see if that holds up for the rest of the triple agent class, and then what else might be done with that, because clearly if you could get that kind of lowering, right, that would be fantastic, but patients have to tolerate it. I will be intrigued to see what else develops in that class and what we're able to learn about that agent as time goes by. Couldn't agree with you more on that. Are there anything in the patient or the advanced provider sessions that you've looked at that's of interest to you?
One of the areas that I'm always interested in, and we've kind of touched on this a bit, is the implementation of obesity pharmacotherapy in the treatment of MASLD. And there's a session on this specifically directed towards hepatologists. And so, this is something that as an endocrinologist, this is what we do every day. And I'm also, an obesity medicine physician. And so very familiar with these medications and how to use them, but they're underused and there's not enough of us to treat the patients. And a lot of these patients are presenting in the hepatology clinic. So I think it's very useful to have a discussion on anti-obesity medications and how hepatologists can use those. So that looks like it's going to be an interesting session.
Yeah, our friend Ken Kuzi keeps making the point that not only are we asking endocrinologists to be more like hepatologists, but we're going to ask hepatologists to be more like endocrinologists, if you will. And I think the anti-obesity meds and the incretins are going to be one of the places where the rubber meets the road on that one. Can we get hepatologists more comfortable with GLP-1, with the dual agents and all that?
I agree. And really to be familiar with just treating obesity in general, because we have other tools in the toolbox, other medications for obesity. And the reality is anything that helps with weight loss, if you can get that 5% or even better, 10% weight loss, you're going to see improvement in liver fat, and with 10% maybe improvement in fibrosis. And so getting people familiar with these medications, I think it's okay. I don't think that the internists, the family practice doctors, or the endocrinologists are going to be offended if we see more use of these medications, because there's just more need for people prescribing them.
Yeah, it's interesting you say that. One of the points I've been captivated by in the last couple of months is the Lancet paper that suggested 1.5 billion people living with diabetes by the year 2050 around the world, which says to me everybody needs it. If everybody does everything they possibly can, we still probably will not get on top of this, but at least we'll do better with it, because the social factors, the social determinant of health factors, the dietary factors, and all those things that are driving more people to metabolic disease and diabetes, those are going to be hard to curb.
Very true. And, I know that the American Diabetes Association has really taken on MASL as one of their major areas of focus, and they're currently working on a consensus statement for MASL. And so it's really, you can't talk about diabetes now without talking about it.
Well, it's good. I think that's probably how it should be. All that stuff should roll together. All right. Any closing thoughts as we get to the end of our half hour here?
Well, I would just say that, as an endocrinologist, it's exciting to go to a liver meeting because it's something different. A lot of my colleagues don't attend these meetings, but now I have all my hepatology colleagues, and it's so fun to go to the meetings and to meet the people that you've been reading their papers and to see your friends. And so I'm really looking forward to seeing you and to seeing everybody in Boston.
It'll be fun. I look forward to seeing you there. So, Scott, thank you so much, and we'll see you in Boston, okay?
Thank you.
Thanks.
See you in Boston.
Bye-bye now. Hope you enjoyed our interview. That concludes our week of liver meeting preliminary interviews. We will be back on Wednesday, November 8th with a group discussion, typical Surfing NASH panel with Jorn, Louise, a couple of other guests, discussing some of the specific papers we're most excited about. Until then, have a great weekend. Stay safe. Surf on. I'll see you next week on the podcast. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.